Thank you for coming. This is an update on valvular heart disease. We are going to talk about the latest guidelines and guideline-directed care for patients with aortic stenosis, aortic insufficiency, mitral valve disease, and tricuspid valve disease. The focus of this talk is really on catheter-based procedures. We're going to talk about TAVR and all the TAVR variants, MitraClip procedure, and then I am going to touch on the angiovac procedure at the end because the valve team is involved in angiovac going forward. And then we're going to talk about some clinical trials that we're involved in here at Maine Medical Center, and of course we're going to talk about our data as we go forward. So in early 2020, before the pandemic, pre-pandemic, the ACC-AHA guidelines came out, updated for management of patients with valvular heart disease. And we were really excited in the beginning of 2020 to spend weeks and weeks digging through these guidelines in our weekly valve conference, just picking them apart detail by detail and going over them with a fine-tooth comb, and then a pandemic hit. And so then we had to do that in the setting of a pandemic, which made it a little more challenging. But still, these guidelines are really the basis for the care for the heart valve team here at Maine Medical Center. Aortic stenosis is kind of the backbone of the heart valve team. It's why we started as a team. Initially, people always refer to us as the TAVR team because when TAVR came along, that was really the impetus for initiating a multidisciplinary heart valve team. And so aortic stenosis and bioprosthetic aortic stenosis, AI, are part of the guidelines. The diagnosis is made by transthoracic echocardiogram in these patients. And so having a good quality echocardiogram and a good reader and reviewer is very, very key. We struggle sometimes with outside echoes with machines and technicians that just are not really getting good images for us, and sometimes we end up having to redo. We do know that there are some patients with what we call low flow, low gradient, severe aortic stenosis. And those are patients sometimes with a low EF. And sometimes you can give those patients dobutamine, a stress test by dobutamine to see if they have any contractile reserve of the ventricle, and that will help clarify even though they don't meet gradients. Traditionally when we look at high flow aortic stenosis, they need a mean aortic gradient of at least 40 millimeters of mercury, a mean velocity greater than 4 meters per second squared, and a valve area less than 1. And so if they don't meet those criteria, they certainly may have low flow, low gradient, severe AS, but we still have to demonstrate that that is true. And some patients have what we call paradoxical, low flow, low gradient, severe aortic stenosis. They don't meet gradients, and there are multiple reasons for that. They might have AI or they might have MR, just kind of contaminating the numbers that we're getting. And in that case, we look at certain parameters, the ratio of the outflow tract to the aortic velocity, and that's really where a good quality echo comes into play for us. And then certainly there are some of those patients with low flow, low gradient aortic stenosis that we think is severe, with either reduced or normal EF. And the guidelines now allow us to use the aortic valve calcium score on the CT. And so when we do TAVR CTAs here at Maine Medical Center, they're gated to calculate a calcium score of the aortic valve alone. So there's calcium around the aortic valve, and there's calcium on the mitral valve. And what the radiologist will do is really pick apart and see what calcium is on the valve. They quantify that. For women, a calcium score greater than 1200 is considered severe, and for men, a calcium score greater than 2000 is considered severe. There's not really any data to know how to trend those over time, so we take a single calcium score and count it. And I always tell John Lawaldi that the way to remember which is which with a male and the female score is that the women only have to get a calcium score of 1200 and the men have to get a calcium score of 2000, and it's kind of the only thing in the universe that you will find where women have a lower bar than men to achieve. So now he remembers it. So TAVR is the FDA-approved treatment. If patients are not surgical, in 2011, TAVR was FDA approved for patients who are at high or prohibitive risk for open heart surgery. So when we're calculating a patient's risk, we're not calculating their TAVR risk. We're calculating their surgical risk, and therefore declaring that TAVR is an appropriate use, an appropriate alternative to open heart surgery. And so in 2011, it was patients just at higher prohibitive. In 2016, it expanded to patients at intermediate risk. And then just in 2019, TAVR is now FDA approved for patients at low risk as well. So really now TAVR is FDA approved for all aortic stenosis that is severe and symptomatic. It is also approved for bioprosthetic aortic stenosis or bioprosthetic aortic insufficiency. We call that valve-in-valve TAVR. Native aortic insufficiency without severe aortic stenosis, though, is not an indication for TAVR and not an FDA-approved use. So we have to be very careful when we're evaluating patients to really suss out the appropriate use of the guidelines. The guidelines, again, really emphasize and require that we have a multidisciplinary heart valve team. That's an FDA requirement. It's a Medicare requirement as well. We have to show that a cardiac surgeon has evaluated the patient for surgery. We have to show that an interventional cardiologist has evaluated the patient for TAVR. And we have to show evidence of shared decision-making. And there are a number of key points that we are required to document for the registry and for reimbursement for the procedure, quite honestly. We kind of always feel at Maine Medical Center that we do a really good job with our multidisciplinary heart valve team. A lot of programs send the patient off appointment by appointment, and the team is never really together. We see our patients together in clinic. We have dedicated valve clinics 4 days of the week. On Tuesdays, we are out in Scarborough on the second floor seeing patients. On Wednesdays and Thursdays, we're here on P2D seeing patients in between cases in the OR. And then on Fridays, we're back out in Scarborough seeing patients. We see the surgeon and the interventional cardiologist and the imaging cardiologist and the coordinator see patients together in clinic. So it's a crowd of people that go in and see the patients, but we really feel like the team has good rapport with all the members of the team, and the patients really give us positive feedback that getting everybody together in the same room for the same conversation is really beneficial to them. So I think it's good patient care that we do that. In addition to that, our heart multidisciplinary valve team here, we have a weekly valve conference that's Tuesday morning. It's a multidisciplinary review of all the data on patients. We review that week's cases. We create worksheets, which are basically checklists for every surgical case. And then we review different new guidelines that come out in studies, so there are educational offerings. The surgeons attend, the interventional cardiologist, the imaging cardiologist, the OR staff, the cath lab staff, the radiologists attend and review everybody's CT scan with us that's planned for the week. So it's really a robust conference, and we enjoy it a lot. So we keep each other current. The full evaluation for patients with suspected severe aortic stenosis. As we said, there's the heart valve team. The diagnosis is made by echocardiogram. The diagnosis is sometimes aided by that TAVR CTA, but in addition, the CTA gives us the annulus size. TAVR comes in 4 sizes. We use the Edwards valve, which I'll get to in a minute. And so we need to know what size valves to put in the patient. It also shows us the morphology of the valve. We find a lot of bicuspids by CT scan that really aren't picked up on echo. So the CT is very, very valuable. It also shows us the iliac anatomy to know if we can get our catheters up by going through their leg. And if we can't go through their leg, is there alternative anatomy that we can go through? Every patient having a TAVR needs a cardiac catheterization. We do right heart caths, and we do coronaries on everybody. Patients who are valve-in-valve patients or bicuspid or have had adjacent valve surgeries or have some kind of funky morphology, we also do a TEE. TEEs used to be standard workup for everybody getting a TAVR, and they are not anymore, except in these circumstances that I outlined. And so sometimes we consider it and sometimes we don't. And then again, additionally, we evaluate the age of the patient. That's become more important in the guidelines as TAVR is now FDA approved for everybody, that a 50-year-old getting a TAVR is very different than a 90-year-old. So the age factors into it. Patients with atrial fibrillation factor into it. Patients with pre-existing conduction disease factor in. If they've had prior surgeries, have they had a prior sternotomy in the past? Do they have other comorbidities like severe lung disease or some kind of cancer that's ongoing? And what are their symptoms? And again, TAVR is FDA approved for severe symptomatic aortic stenosis. Surgical AVR, patients can be asymptomatic, but to get TAVR, you have to be symptomatic. This is a really busy slide. The green parts are sort of the newer endpoints in the guidelines. It just basically talks a lot about age-based decision-making. And so the guidelines really delineate now for patients who are less than 65 years of age, that you expect they have more than 20 years left to live. Surgical aortic valve replacement is preferred over TAVR. Now, of course, there's shared decision-making with that patient, and TAVR is FDA approved for people younger than 65. But we would want to have a good conversation with that patient and help them understand why surgery is a better option for them. The guidelines then delineate that people in the 65 to 80 years age range that don't have an anatomic reason not to do TAVR, that both are good options for them. And it really is up to the patient and a good conversation with the patient and the providers to help them decide what's going to be the best choice for them. And then for people over 80 years old, TAVR is the preferred method unless there's a reason anatomically why they can't have TAVR. We sent an 89-year-old patient to open heart surgery for CAB AVR because their TAVR anatomy was horrific. They had calcium in the outflow tract and some very high-risk features on their CAT scan, which made TAVR higher risk than surgery. But it was a very robust 89-year-old, and we felt, had to take a really good look at him and consider that he would recover from an open heart procedure. And so now that TAVR is FDA approved for all comers, we really are planning for multiple valves in patients. When a 70-year-old patient comes to us, they're going to outlive whatever valve we put in them, whether it's a surgical valve or a TAVR valve. And so we need to talk to them about this valve and the next valve and possibly a third valve if they live that long. So there's a little bit of consideration. We try to limit the number of sternotomies in their lifetime to one if possible. And that thinking in the guidelines for surgeons is actually quite new. It's quite a shift for surgeons to say, sometimes we push patients to surgery early on to get a good surgical valve put in there and one sternotomy and promise them their TAVR later on in life. And then the other thing we have to think about is future coronary access. So patients with sort of moderate coronary disease, and we say, go ahead and we're going to do TAVR, you have to look at the TAVR valve to see this lovely stent framework that it sits on. And you have to, if that sits higher than the coronary ostia, in order to access the coronaries, you would have to thread that needle and get through the TAVR valve. And when we do valve in valve, it's not always possible to line up the struts of the valve with the struts of the prior valve, and the valves have changed over time. And so you might jail the coronaries by doing a valve in valve. And so that's part of the analysis that the Edwards team does for us now in some patients with coronary disease, is looking at the future implications of needing to do a PCI that we might not be able to do if we put a second valve in. So this is the Edwards Ultra valve. And this is the third generation of the valve. There's a metal composite frame. The inside of the leaflets that open and close in this valve are made from bovine pericardium. They are stamped out in California. Irvine, California is where the factory is. And then the fabric along the bottom, you can see how it comes up 2 or 3 levels in those struts. The fabric is called the skirt. It's a polyethylene fabric, and it expands when it hits the patient's bloodstream to help decrease the amount of paravalvular regurgitation. It's been really quite effective. The original Edwards valves did not have a skirt on them at all, and it was very common for patients to leave the OR with mild to moderate AI paravalvular. And so now we rarely see mild. We should never see moderate. But a lot of times patients have traced to really no AI, which is wonderful. So the procedure itself is usually done femorally through femoral access. We go up through the iliac artery, up the aorta, over the arch and across the valve with a Edwards valve crimped down on a balloon catheter. At the time of inflation, there would be pre-positioned temporary pacer wire in the right ventricle. We rapid pace the heart at about 180 beats per minute for about 10 seconds at the time of deployment so that their blood pressure falls and their cardiac output falls. Otherwise, they would spit the valve out into the aorta, obviously. And so patients that can't tolerate rapid pacing, we have to evaluate that first. Patients with severe coronary disease, patients with really low EF are at risk for having issues when we rapid pace. But that's basically the procedure. At the beginning of the procedure, there's an A line put in one of the radial arteries. There's a pigtail put in the opposite radial or in the opposite groin. The right IJ line goes in for the anesthesia medicines and for the pacer. And then the big sheath would go in the groin site if we're doing groin access. The procedure takes about an hour overall, and then the patients go to PACU from there. Slide 10. There we go. The complications of the procedure are those you would expect with any cardiac procedure. There's a risk of stroke, MI, annulus rupture, dissection of the aortic root, access site complication. They could have a bleed at the femoral site. If we've done TEE with the procedure, then certainly all the complications that could arise with TEE come into it. And then certainly worsening of some of their pre-existing comorbid diseases like Parkinson's and MS, if they have it, that giving them, and those are anesthesia complications. They really have nothing to do with TAVR. But we take all that into account when we're signing patients up for the procedure, that there are certainly complications that are related to the valve and complications related to the other procedures done at the time and complications related to anesthesia, and they just need to think about all those things. Our program here at Maine Medical Center last year during the pandemic was awarded one of the top 1.3% of heart valve programs in the country. So we're very proud of that. We didn't get a plaque on the wall or anything, but we are very proud of that. It's based on the metrics that we are required to submit to the National Registry, our volume data, our mortality, stroke rate. You can see all the data points. There are pages and pages of data points. Trudy Kent is our data manager at this point, and she uploads all our data to the registry and tracks it. We just did an audit with the registry not very long ago and did very well. But it's a lot of required information that we are required to keep on these patients. So here at Maine Medical Center, for you to talk with your patients that you see, last year during the pandemic, we did 233 TAVRs. In 2019, for comparison, we did 240. And I know where those 7 cases were lost. We tried to match 240. Very early on in the pandemic, we met with Marco and Butzel, who are co-directors of the program, along with Scott Buchanan, and we sat down and we looked at where we were at that point in the pandemic, and we went back and pulled our 2019 data to see how our volume was off in terms of clinic visits and procedures. Then our goal last year was to match 2019 and not lose ground, and we certainly didn't think we would grow by 20% during a pandemic, but our goal was just to kind of stay the same. We were pretty close, so we're happy with that. Those 7 cases account for people taking time off and vacations away, so that's okay. During the pandemic as well, because these patients had aortic stenosis, we were part of the system of surgeries. Elective surgeries were all canceled and shut down. TAVR was exempt from that on a case-by-case basis, and so every week we presented the patients that we wanted to put forward to a panel of surgeons and physicians who were not on our TAVR team. And that was hospital-wide, that we triaged our patients week by week and did symptom check-in to make sure that their symptoms weren't escalating and they didn't need to come into the hospital. Jess and I reached out and called everybody who was waiting for surgery. We called high-risk patients in the clinic that we identified could be at risk for decompensating while they were waiting at home. And we tracked all our canceled patients to make sure that nobody got lost to follow up. And we were one of the first programs to return to in-person visits rather than doing visits over Zoom and over the phone. And it just became really hard for us. We would have the whole team on speakerphone and the patient on speakerphone on the other end, and we just decided that we need to look at these people in person and evaluate them in person before signing them up. So it was a bit of a struggle at the beginning, but found our footing. So here at Maine Med, you saw our volume data. Some of the additional data points that we are required to track for the registry. Our mortality rate is 1.3, and nationally, the mortality rate runs around 2%. So that we're under the national mortality rate is always good. Our stroke rate at 2% is right in keeping with the national data as well. So we like to see that right at 2%. It's about 1% major stroke and 1% minor stroke, like a visual field cut or something that resolves very quickly over time. You know, the data is kept on rolling 4 quarters. So one bad quarter of strokes can really affect your data for several quarters to come. Sometimes our stroke rate ticks up a little bit if we have a flurry of people who have a stroke post-op instead of just 1 stroke a quarter, which would be nice. But at this point, our stroke is right in line with the national information, so that's good. Our vascular complication rate is a little bit high at 6.9%. I think that nationally the vascular complication rate is around 4%. And so in the last 4 quarters, we have had some vascular complications. Sometimes if the femoral axis is tight, it isn't getting the catheters up and in that will cause a complication. It's getting the catheters out at the end of the procedure. And sometimes the tissue is very friable. And when we're taking the catheters out, we cause a vascular injury that requires either vascular surgical repair or a cut down, and for the cardiac surgeon to do a repair right there on the table. So, but we would like to see that number. So when this happens to us and we see our numbers tick up, we immediately do case reviews. We look at the patients that had complications. We always do a deeper dive into those charts, and then Jess and I will usually present that back to the group so we can see if we can figure out any trend or pattern so we can immediately get that number back down. Our aortic insufficiency post-TAVR is 0, as it should be. Our new pacemaker rate is 7.6, which is actually right in keeping in line with the national data. So sometimes patients require a pacemaker as a consequence of having a TAVR, and that has everything to do with the conduction system anatomy between all the aortic valves. So when we push the new valve into the annulus tissue pushes into the tissue around it. We know that patients who come into TAVR with a pre-existing right bundle branch block have a 30 to 40% rate of needing a permanent pacemaker versus patients with no bundle or a left bundle only. And so sometimes patients who come in with the right bundle, we'll go ahead and pre-consent them and explain the pacemaker proviso to them. But our 7.6% pacemaker rate is not surprising and is right in keeping with the national data, so that's good. We have 95% follow-up at 30 days. We're required to see patients at 30 days back in clinic with an echo and a visit, and about 75% of those patients have acceptable quality of life at 30 days. We do a questionnaire called the KCCQ, the Kansas City Quality of Life Questionnaire. And so sometimes that other 25% whose quality of life is not great is not necessarily because of TAVR, but it just tracks overall quality of life. And then a little more information about our program in particular. About 60% of our cases are done under conscious sedation now without need for intubation. So still that other 40% that requires general is either because we need to control their airway or they need a TEE at the time, either to determine sizing if we couldn't do a CAT scan, or if they're in between 2 TAVR sizes and we need to do a TEE at the time to just sort of break the tie. About half of our patients are discharged on post-op day number 1, and a good 95% have gone home by the end of post-op day number 2. So it's really a 1 to 2 day post-op stay in the hospital at this point. And over 90% of our patients are done transfemorally. If we don't have transfemoral access, the next access that we will look at is going through the subclavian. If they don't have good subclavians, the next access we would look at is going directly either through a right anterior thoracotomy or through a mini sternotomy directly into the ascending aorta. If we can't get into the aorta because they've had prior bypass surgery and we don't want to risk damaging a lima, sometimes we can go directly through the 4th and 5th left intercostal space and go directly through the apex of the heart. And it's a straight shot from the apex up to the aortic valve. And that is the most surgical of approaches. Patients are usually in the hospital a good 4 or 5 days after that. It's no less than open heart surgery, the recovery. And it is actually quite an uncomfortable recovery. They have quite a bit of pain from the tissue around that. And we do carotids. I kind of skipped over carotids. We've done a handful of them. I never sleep well the night before we do a carotid case. And when we do carotid TAVR, we do EEG imaging throughout the case, that we have somebody bring in and set up all those little sticky dots on their scalp. And we do, addition to the regular workup, we do carotid ultrasounds, and we would also do CTA of their head and neck to verify that their circle of Willis is intact. And then the average age of our TAVR patients is still about 86. It has been that way since I joined the program 5 years ago. I keep waiting for it to go down now that in 2019 with the FDA approval for everybody, I keep thinking we're going to TAVR younger and younger people. And that's true a little bit, that the age of TAVR patients has gotten younger, but we also are moving upwards and doing more 90-year-old plus patients. And so I think it's just really holding that at mid-80s. The oldest patient that we have ever TAVR'd in our program is a 97-year-old, and she did fabulously the next morning. She had her lipstick on and her hairbrush and her makeup applied by 7 a.m. when we rounded. And she would have gone home post-op day number 1 had everybody just not thought that that was just wrong for a 97-year-old. So we kept her a day to just stare at her. But she's doing great. We do know that patients in their 90s have a higher complication rate, though. This is something that we are continuing to pull out and study as a quality initiative with our team, are looking at the rates of complications in 90-year-olds, which makes a lot of good sense. It's one of the things we try to prove. So our team, other than all the required data collection for the registry, we are a very data-driven group. We ask a lot of questions. And so we try to do some QI presentations among the team and to kind of suss out some of those answers. And these are just some of the things that we've looked at. We've looked at our GI bleed rate, which actually drove us to change our anticoagulation strategy on most patients. We used to give everybody Plavix for 6 months after the valve and a baby aspirin indefinitely. And now the standard of care for us is a Plavix load after TAVR, and then home on aspirin if they're not on another anticoagulant. So we drop the Plavix, and our GI bleed rate has come down. If patients are on, a DOAC or on Coumadin, we might just leave them on a single strategy. We'll still give them that Plavix load, but we wouldn't necessarily add aspirin if they don't have another indication for that baby aspirin. We had a cancellation, a little tick-up rate in our cancellations due to false positive UTIs, and that caused us to look at our pre-op orders, and that, the IDSA guidelines for collecting UAs standardly on all pre-op patients is no longer, and so we stopped collecting UAs except for patients who are symptomatic. So we screen for symptoms and not just blindly get a UA anymore. We're looking at our complication rate in 90-year-olds. We look at that heart failure readmits. This is something that was started before my time here to look at readmission rates. And the driver of our readmission rate at that time was heart failure. And so now patients with pre-existing heart failure or prior hospitalization for heart failure as part of their TAVR workup will get a heart failure consult on post-op day 1 just to help manage the medications as they walk out the door, so that will hopefully keep our readmission rate down, and that has served us well. And then the current thing we're working on is trying to get central lines out the same day. In the post-op surgical world, central lines stay in, and so it is a change for the nurses on our 1 to take out a central line the same day as the procedure. And what we've added that to our rounds at night when cases are all done and clinic is all done. The last thing we do before we leave for the night is walk around and round on those patients one more time. And at that time, Jess and I or Butzel will go ahead and put the order in to take out those central lines so the nurses don't have to call the APPs on the surgical team and kind of wonder because they were defaulting to just leaving the line in until morning, and patients are much more comfortable if that line comes out. So one quick slide on bioprosthetic AI. It is an FDA-approved indication for TAVR. We need to make sure that the AI is intravalvular and not paravalvular to consider TAVR. So, if you think about putting a new valve inside the struts of that pre-existing valve, it makes just common sense that if the leaking is all around the valve, that unless you push the old valve into all that leaking tissue, that you aren't really going to fix paravalvular regurgitation by putting a TAVR valve in. So that again would require a TEE to really suss out where the regurgitation is coming from. My experience with patients with AI is that they can decompensate and just drown very, very quickly. The only Monday morning emergency TAVR that we have ever done was on a patient with bioprosthetic AI that was just in cardiogenic shock and struggling because his valve was just wide open. When the leaflets of the TAVR valve give and tear away and there's wide open AI, it's just, it's an emergency practically in those patients. And so again, for those patients, the surgical valve size matters. In smaller valves, when we put a TAVR in, we're just going to make that opening smaller. And so it really depends on the other factors. If the patient is older and their life expectancy is somewhat limited, putting a smaller valve and living with higher gradients, but fixing the AI might be reasonable. But in other circumstances, we might recommend that that patient go have open surgery and a root expansion and put a bigger valve in, so that going forward, we have a bigger valve to start putting TAVR valves in as we go forward. And then there is a procedure called cracking of the old valve. We're not proponents of cracking the valve. It is part of the guidelines. It stayed in the 2020 guidelines, and there are some centers that crack the valve. And it is what it sounds like when you place the new TAVR valve. You use a Kevlar balloon and actually push against the old valve hard enough to actually break that valve and crack it open and enlarge the opening. Edwards is working on a valve that has sort of a sliding base so that it isn't really cracking the metal of the valve, but allowing the valve to expand. And that is still in clinical trials. We have cracked the valve a couple times in this center. It's not something that our interventionalists are inclined to do. I have a single slide on TMVR, which is something that's just really interesting to me. TAVR is FDA approved in the mitral position if the patient has a failed bioprosthetic mitral valve. If they have just a very calcified native annulus, we would call that valve in MAC, and that's actually in clinical trials, but it's not yet FDA approved. The outcomes for that are so far, the centers that are studying that, the data is not great, so it's really kind of an interesting technology. But we have done a handful of cases in patients with bioprosthetic mitral valves where we have gone up to the right side of the heart, crossed the septum, and then put a new TAVR valve across a bioprosthetic mitral valve. The Edwards system was not designed to do this. It's a struggle of a procedure. It creates, an ASD that the patient then, who should hopefully heal, but it's a struggle of a procedure every time we do it. So it is an FDA-approved use of the TAVR technology, but it's not something that's common. There just are low numbers out there, and it, for us, is a bit of a high-risk procedure and a low-volume procedure, which always makes things high-risk. Again, those patients would require a TEE as part of their workup for the bioprosthetic valve, and the CAT scan is a different CAT scan. It's a CT cardiac adult. We don't need to look at their legs and their access that way because we're going venous, but we need to gate that CT cardiac and send it off to the Edwards team, and they actually send it on to specific imagers to work it up. It's a very high-level analysis. And then another component in the guidelines that is new with this iteration of the guidelines is really addressing patients with elevated gradients after TAVR and sometimes after SAVR as well. I think in the surgical AVR world, the surgeons don't check echocardiograms postoperatively on surgical valve replacement. They defer those patients back to the cardiologist to follow those gradients going forward. And that's something that we've talked about as a multidisciplinary team, that there's a discrepancy in care there. But we are seeing patients with elevated gradients after their TAVR procedure. The studies to look at what to do with them and how to manage those patients are very small and non-randomized studies at this point. So the guideline, the recommendations from the guidelines are not 1A classifications as well by any means. The highest incidence of elevated gradients we see in the first 3 months. So typically when we bring the patient back for their 1-month visit, if we see the guidelines rise by about 10 millimeters of mercury or more in the mean, that's really not part of the guidelines. That's kind of anecdotal from being in clinic with Lawaldi and Diaz and Hillstrom, that about a 10 millimeter rise, we might, one of two things, depending on how symptomatic the patient is, you might just check an echo in 2 to 3 months and follow serial echoes to see if the gradients continue to rise. The other strategy is to get a CT cardiac adult gated scan to assess for leaflet thrombosis. And you have to specifically type in the indications that you want the radiologist to assess for leaflet thrombosis. The CAT scan is the preferred method of finding leaflet thrombosis over TEE actually, but if the CT is unclear, we still will go in the reverse direction and get a TEE and have one of our imagers really look for leaflet thrombosis. The strategy then, if the gradients are up and we do find leaflet thrombosis, is Coumadin for 3 to 6 months and then to reassess that. There's very little data on how long the Coumadin should go or how high you should run the Coumadin, so it's a standard INR of 2 to 3, and 3 to 6 months is really just clinical experience and anecdotal, but a period of time, and then look at the echo again, and then take the patient off the anticoagulation, and then reassess the echo about a month later to see if their gradients stay down or if they continue to go back up. We do have a patient, a single patient in my recollection, that is on a DOAC for elevated gradients, but it was a patient that really just could not manage Coumadin. And so that's kind of part of the discussion in TAVR patients. Even if it's somebody who's not on Coumadin initially when we place their TAVR, it's a conversation that we have. If there are patients that absolutely cannot be anticoagulated, it's just something that we have to have that conversation with them going forward, that if their gradients elevate and the answer would be to anticoagulate them, but they cannot be, that's something we would have to consider. We had a patient during the pandemic who was in her early 60s, and she had a surgical valve, and then we TAVR'd her. She was a terrible surgical candidate, and she had a mean gradient in the 70s, and it was thrombus. And then really the only answer for her, she just was not, we had her Coumadinized, and her gradients were not coming down. In fact, they elevated on Coumadin. And so the answer for her was to have her valve surgically explanted and replaced. And she was a very high-risk surgery, but she did okay with the surgery, and it was successful. Okay, I'm going to move on to the mitral valve now. Mitral regurgitation is, and mitral valves are more complex, I think, in my opinion, than talking about aortic stenosis. So in mitral regurgitation, we're talking about 2 different types. Is it primary mitral regurgitation or degenerative mitral regurgitation, which is a problem with the valve itself? Is there a perforated leaflet, a cleft? Is there prolapse, thickening, fusion? Is there a rheumatic valve, something like that? Versus secondary or functional MR, which is a problem with the ventricle, whether there's papillary muscle ischemia, distension of the free wall due to ischemia, if there's dilation due to cardiomyopathy. And so that's really where the leaflets of the valve aren't prolapsing and the valve structure itself is normal. It's just being pulled apart by an expanding ventricle or expanding atria. And so it makes a big difference. And sometimes patients can have components of both. In that case, we would call their valve myxomatous or fungenerate, if you want a better word for that. The MitraClip procedure was approved as an alternative to open heart surgical repair of the mitral valve in primary MR only back in 2013. So all these patients walking around with functional MR were not MitraClip candidates until very, very recently. In 2019, the FDA approved MitraClip based on the results of the COAPT and the Mitral FR trial for patients with functional MR. So now MitraClip is approved for both types of MR, but still those patient populations are very, very different. Again, this is a very busy slide. This is looking at primary mitral regurgitation, again, an issue with the valve itself. If you go down to the bottom line, that's basically it. The answer is surgery, 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 open surgical repair at a valve center of excellence. And so there's only one indication in primary MR, and that's if the surgeon turns the patient down. If the patient is too high or prohibitive surgical risk, then the surgeon will say, I think this patient is an appropriate candidate for MitraClip. But everybody else with primary mitral regurgitation is a surgical candidate, and that's still the gold standard of care. Secondary mitral regurgitation, well, remember that's a problem with the ventricle and not the problem with the valve. These patients are much more complex, and as you can see right here in the guideline, is guideline-directed medical therapy supervised by a heart failure specialist. So these patients need to be tuned up, and once they're on optimal medical therapy, relook at their echo and see if their MR has improved. And the reason for that is that in the COAPT trial, about a third of patients peeled off at that point and were no longer had severe mitral regurgitation once their medicines were optimized and their heart failure management was optimized. So we can save about a third of patients coming in from needing any type of procedure whatsoever just by optimizing their heart failure therapies. And again, if patients have other indications for surgery, if they need a CAB, then they're going to get open surgical repair, which again is still the gold standard. The only patients in this category that we're going to consider for MitraClip, which as you can see in the guidelines, we're starting to call transcatheter edge-to-edge mitral valve repair, or TEER for short, T-E-E-R, are patients with EFs that are below 50, so even the low normal patients could go to surgery. So EF below 50 with persistent symptoms and still have severe MR once they are optimized on medical therapy. Their mitral anatomy needs to be favorable. Again, we do a TEE to look at their mitral anatomy. We upload that to the Abbott team that makes the MitraClip device to make sure that it's a clippable device. It used to be, doing a clip has expanded a little bit. There are now 3 different types of clips available to us. Some are longer, some are wider. So the strategy in the operating room, we look ahead at the TEE with the imager. The imager drives a lot of this procedure to talk about what type of clip we're going to use first, whether we need to use a wide clip or a long clip or a standard clip or a combination of the two. Some of the really important points when we're thinking about patients with valvular disease is that about 15 to 20% of patients with severe aortic stenosis will also have significant MR. And we know that then turning that patient from an AVR, surgical AVR, into a surgical AVR, MVR has increased mortality. We use the STS calculator from the Society of Thoracic Surgeons to calculate patients' surgical risk, and there is no calculator for double valve surgical replacement. So the surgeons are fighting a little bit blind here because there's no big national database to plug the patient's data into and help understand their actual risk for surgery. Patients with severe MR and a normal EF can also have low flow, low gradient aortic stenosis, and it's thought that the MR influences and diminishes forward stroke volume. So sometimes in multi-valve disease, what you'll see are patients who present with low flow, low gradient AS, and that catches everybody's attention, but then lo and behold, they have severe MR. The strategy in that case is going to fix the AS first and then bring the patient back to clinic for their 1-month visit and re-look at that echo and see what has happened to their mitral regurgitation once we've fixed the aortic stenosis. And this is just where the future is headed. Here's a patient with his TEO probe. He's got his TAVR and he's got his MitraClips all in place, all his hardware. So here at Maine Medical Center, during the pandemic, we got funding approved to focus on our mitral program. And the plan had been all along to become a mitral center of excellence, which is a specific designation based on volume and outcome criteria. The goal was to increase our mitral consults through the valve clinic for all patients and improve our outcomes after MitraClip and after open surgery as well. We have dedicated mitral surgeons, dedicated interventional cardiologists, and dedicated imagers in our program. And at the beginning of 2020 and revamping this, our imagers and our interventional cardiologists did additional catheter-based training to kind of relearn the MitraClip procedure, which had changed over time since 2013 when some of these guys first learned this procedure, because the MitraClip itself is now in newer generations and has changed a little bit. We are still a multidisciplinary model on our mitral clinic component. We have dedicated mitral time in our clinic monthly. We have a specific day that we line up all our mitral patients that we have that specific mitral team. Dr. Quinn is our dedicated mitral surgeon at this point. We have a new cardiac surgeon who's starting in September, and he's a mitral experienced surgeon, and he'll be joining our mitral team as well. At this point, the interventional cardiologists on our mitral team are Dr. Butzel and Dr. Berkey and Dr. Frey. And then the imaging cardiologists who are on our mitral team at this point are Dr. Lualdi and Dr. Diaz. And the reason for kind of honing down the team from the larger dedicated valve team is just that we're trying to really re-engage our mitral program to build this center of excellence. So we really have to have a very small and focused team to have excellent outcomes to kick off our team going forward. I think I finished talking about that. We have dedicated OR time monthly as well. So we can plug MitraClip procedures right into the schedule. There are days that we know that the MitraClip team, whether we have MitraClips or not, is going to be in the OR so that we can easily move these patients into the schedule. And then we have dedicated echo time as well. Those patients needed TEE as well as a good quality TTE. They don't always need a cardiac catheterization. It depends on if they have prior coronary disease and what their heart failure status is. They need to see a heart failure specialist and have guideline-directed medical therapy if they are functional mitral regurgitation. And then they also need to have the conversation and be considered for CRT. And so the workup is actually a slow motion, time-consuming workup in these patients, because before we agree to MitraClip a functional MR patient, we need all this data. We need their heart failure optimized. We need their heart rhythm optimized. And then if they still have symptomatic and moderate to severe MR, then we'll consider them for CLIP. We do, again, a 1-month follow-up in the office. After MitraClip, the surgical repair patients were not getting that same follow-up. At this point going forward with the development of our Mitral Center of Excellence, we're working on developing a pathway so that when those patients go back to see the surgeon in their post-op visit, they'll get an echo at 6 to 12 weeks after their surgery that will come back to the valve team so that we can track our repairs. That's kind of an internal registry that we're starting. And then we'll see those patients, even though they went to open heart surgery, we'll see them back in valve clinic at the 1-year mark for an echo and a visit and follow-up. So to specifically talk about MitraClip, as it's called now, TEER, or transcatheter edge-to-edge repair. Again, surgical repair of that valve is still the gold standard. But as we said in the guidelines, if the surgeon feels that the patient is high to prohibitive risk for open surgery, they will tell us to consider MitraClip. So it requires a surgical turn down. We do the MitraClip procedure under general anesthesia, and it's TEE guided. And it really is guided by that imaging cardiologist manning the TEE and being the eyes for the interventionalist on where to position the clip and how to position the clip. It's a 1 to 4 hour procedure. There's venous femoral access gained, a transeptal puncture from the right atrium to the left atrium, and then the clip itself is turned on a 90-degree axis, crosses the mitral valve, and then deploys on the mitral valve. These patients have just a 1 to 2 day post-op stay on our 9. We have, as part of our Mitral Center of Excellence, developed standardized order sets. The heart failure team sees functional MR patients. They're usually already following them, but if for some reason they're not, we have them see them while they're in the hospital post-clip to help discharge planning. And the goal for these patients is really to take 4+ MR down to 1 to 2+ MR. We're never going to get rid of it entirely, but we want to improve their symptoms and their functional status. That marker of improving MR down to 1 to 2+ is also kind of a moving line. The newest iterations of the MitraClip device are allowing us to have less and less residual MR post-procedure. And so now 2+ MR is kind of too much for us. We'd like to see 1+ MR on our patients. Our volume data, just so you have an idea, in 2020, before the pandemic, we did 8 patients, and through the pandemic, and that was all while we were doing all the background work for our Mitral Center of Excellence. We've done 17 patients so far in 2021, and we have a patient this week. So our volume has really gone up substantially because we have put a lot of the processes in place to really improve this program. This is the MitraClip procedure. The slide's a little bit blurry. We come in through the right heart, cross the septum, the catheter turns and crosses the mitral valve. You can see that what it creates are 2 jets across the valve with the clip in the middle. Sometimes the clips need to be placed way out at an edge if the patient has a cleft valve, but it's not the ideal placement. The ideal placement is exactly where you see on that diagram, is that the clip is right in the middle. You can put 2 clips side by side. The longer clips, the longer arms, it would make intuitive sense that you could grab better, but we still need to measure the length of the leaflets of the valve to know that we have enough leaflet to coapt and grab with the MitraClip device. The longer arm is an interesting phenomenon because the device was already FDA approved. The longer arm devices didn't have to go through the same approval, and it turns out that the edges of that, the distal end of the arm doesn't have as much tensile strength. And so the grabbing strength is really back at the proximity, the base of the clip. The wider clips work really well as well, and a lot of times they'll put a wide clip and then a very narrow clip right next to it and use some of the different clip technology. But that's kind of the basic idea, is that you're putting what looks like an alligator clamp right in the middle and grabbing the leaflets of the valve and pinching them together. It's just kind of a different viewpoint of it and what the echo imager sees during the procedure. So again, the catheter has to turn. We go down across the valve, deploy the clip from underneath and come up and grab the leaflets of the valve on a beating heart and clip them together in the procedure. And you can see on the images on the right at the bottom, that is what the orifice should look like when the procedure is done. You should be able to see, you can see the bright white of the clip in the center, so you can see that both arms of the clip are engaged on that patient. All right, so moving on to tricuspid regurg. I see that we're almost out of time, and I'm just going to finish very, very quickly here. Tricuspid regurgitation, this is standalone, is in the guidelines. You can see at the bottom of this algorithm that every patient goes to surgery. We don't have an FDA-approved transcatheter fix for tricuspid regurgitation. There are some devices in clinical trials. The Edwards-Pascal device is being studied in Boston as a tricuspid device. You can see it looks basically like a MitraClip, but it's for the tricuspid valve, and that's in clinical trial. And the reason why we're focusing on the mitral valve, I took a screenshot of this position, as she was presenting the tricuspid data. You can see that tricuspid data is increased with, is associated with increased mortality when you walk away from it after open heart surgery. And that's what really drives us to look at the tricuspid valve when we're doing other valve surgeries and consider that there's something that we may need to do. We're doing a couple of research studies, and we'd appreciate you sending patients our way if you think that they qualify. We're still participating in the early trial, which is enrolling patients with severe asymptomatic aortic stenosis. They would be randomized to either moving forward with TAVR or having surveillance. We are about, I think we have a couple more years left to enroll patients in that trial, and we have fairly low numbers, but that's an ongoing trial for us. So severe AS, but asymptomatic patients. And then we just got approved through the IRB to begin enrolling in what's called the UNLOAD trial, which is patients with moderate aortic stenosis with heart failure and a reduced EF. So we'll be enrolling in that soon. There are studies that we can refer to Boston for patients for tricuspid. And then I just want to quickly touch, I've got 3 more slides if you all can hang on, about the AngioVac device. The AngioVac device is used for the removal of undesirable material in the intervascular area or in the right heart, such as thrombus, emboli, vegetation. We typically treat patients with right-sided endocarditis with this. Maine Medical Center, this is a new program for us. We have a small team. The goal was to look at 10 cases and then evaluate those 10 cases and make decisions going forward about this program. And the goal of it is to really debulk the vegetation or the clot, to stabilize the patient in order to plan for open surgical repair of that valve, or as an alternative procedure when surgical repair is high or prohibitive risk or not appropriate for that patient. The AngioVac is a procedure that would be requested by the MET team, the multidisciplinary endocarditis team, which is a fantastic team. If for those of you not familiar with it, when you call a MET consult, you get cardiology, ID, palliative, ethics, medicine, addiction medicine, and social work all together. And so it would be the cardiologist component or the cardiac surgeon who's been requested to look at that patient, who would say, I think we should consider this patient for AngioVac. That triggers the valve coordinators and the AngioVac specific team of John Fallon and Rader, Estrada, and Butzel. We call a specific meeting to review the data and discuss if AngioVac is appropriate for that patient. And Jess and I were asked to kind of come in and help manage the patients through the 10. And we just got asked, actually they've done like 5, and then they asked us to kind of get in because it's a very complex procedure to coordinate. There are a lot of logistics and moving parts, and in that way it's very similar to the other valve procedures that we do. And so we look at that. Here's a picture of what the AngioVac does. And so the AngioVac cannula goes in the right IJ. The blood moves out of there. It's a little vacuum catheter. It comes down through a filter and then is reinfused, usually femorally. So it's a closed circuit extracorporeal bypass that the patient can be on for up to 6 hours. The AngioVac procedure, in my experience, takes somewhere between 2 to 4 hours. John Fallon, one of our cardiac surgeons, comes with experience from his training center with this. So he's kind of our lead surgeon, and Rader Estrada is our lead interventionalist. Does anybody have any questions or comments?
That was really good, Deb. Jam-packed with lots of good information.
I know. I'm glad you recorded it. There's just always a lot to talk about in the valve world.
There is. The AngioVac is new. I actually didn't even know we were doing that. You said we've done 5 cases.
We've done 6 now at this point. So it's just it is an FDA-approved procedure. It's a low-volume procedure, and here in our population, I think the primary population we've done it on are patients with right-sided endocarditis who are, IV drug users, and they've already had open heart surgery, and we just can't keep doing multiple procedures on them. The last patient we did was a 26-year-old IV drug user who had already had a sternotomy to repair her tricuspid valve. She had a tricuspid valve endocarditis and was still using IV drugs and had made no promises to quit. And the surgeon, wouldn't take her back to the operating room. And so we felt that doing the AngioVac to debulk, she had a massive, massive vegetation mixed with thrombus. on the right side of her heart, that every time her heartbeat shuffled its way out to her lungs. And so it was just really amazing. But yeah, it's just it's a very specific procedure. There, it kind of does have its place in the armamentarium. But for main med, we're just going to do those 10 cases and then have everybody sit together. We'll correlate data on them and look at our outcomes and make some decisions about how much support we have for the program going forward. So
I see.
yeah.
Okay. And then going back, for on average, Plavix after TAVR is about 6 months. I mean, I know if they're on Coumadin, it could be shorter. Did I hear that correctly?
Well, we looked at our readmission rates for GI bleeds, which really drove that data, and that caused us to look at the literature, and it caused us to ask other studies. So how to anticoagulate these patients after TAVR is there's not really any hard and fast literature out there. And so what we landed on about a year ago was to Plavix load them, but not send them out on Plavix. So people that aren't otherwise, if they're on Plavix because we had to do a PCI pre-TAVR, then the Plavix is for the PCI. If they're on, a DOAC or Coumadin because they have AFib, then it's for that. But if they're just TAVR alone and they come in on none of those medicines, we're going to Plavix load them and put them on a baby aspirin and send them on their way.
Okay, I do remember you talking about Plavix load. I didn't realize that was okay.
Yeah, Plavix load only, and then aspirin, unless they have other indications for Plavix or a DOAC or Coumadin, which is exciting. Our GI bleed rates went down, which was very, very exciting to us. So.
Good. All right. That's awesome. Well, thanks, Deb. I will post this onto our Canvas platform, and this was great. Really appreciate it.
Very good. Thank you for having me, and thank you so much, guys, for allowing me to come back. My bad last week in my valve meeting, thinking that that I was going to present at 8 o'clock and not 7 o'clock. In my brain, I thought that timing is going to be perfect.
No problem.
For understanding.
No problem. Thank you so much.
Very good. Thank you.
Bye-bye.
Bye.